evening, everyone, and welcome to today's webinar. My name is Dr. Sara Mqadmi, and I'm part of the Dentrain team. So it's a pleasure to have you join us for an insightful session on pink aesthetics with Dr. Javier Calatrava. Thank you so much for coming, Doctor. Dr. Calatrava is a specialist in periodontology, and he's currently pursuing his PhD in the University of Michigan, which is obviously the top university in the world for periodontology. It's an honor to have you, Doctor. Before we begin, please just make sure everyone that your microphones are muted, and we'll have a Q&A session towards the end of the webinar. You can just write down your questions in the chat box, and we'll happy to address them during the end. So thank you so much, and Dr. Javier, the mic is yours.
Okay, thank you very much for that very kind introduction. Let me see if the presentation is working. Can you see my screen now?
Yes.
Okay, sounds good. So I'll start presenting, and if there were to be any issues, wait 1 second so that this doesn't, there we go. Any issues during the presentation, just let me know. Okay, you can interrupt me at any time. And I'm also gonna set up a timer, not to take too much time out of anyone's Sunday, so that we stay within the time limits. And well, again, Dr. Sara, thank you very much for the very kind introduction. Today, we're gonna be talking about the importance of pink aesthetics within the smile and how to improve them with periodontal surgery, since it's something that sometimes can be overlooked within our treatment plans. You already did much more than enough introduction about myself, so I'm going to skip this slide just to let everybody know, put pictures to the places that you're talking about. This is Universidad Complutense de Madrid, where I did all of my training, and from here last year I decided to travel all the way to the United States, where I'm living right now in the University of Michigan School of Dentistry, where it's actually sunny and warm now. It looks a whole lot like this video, but during the winter, which is 6 months out of 12, it does look a little bit like this. And yes, indeed, it is as cold as everybody says and expects. So the aim of this webinar is to introduce the topic for a course that we'll be having in Turkey at the end of November. In case any of you guys are interested, it's an intensive 2-week course in which there's different sessions. And one of them, which will be the one that I will be doing from this dental bootcamp in November 23rd and 24th in the city of Istanbul, will be again about pink aesthetics, mucogingival surgery, and crown lengthening. And the aim of this webinar is just to introduce a little bit the topic and give some insights about this topic to hopefully get people interested to join us for the full-on course that will be taking place in November. The program for this course will be the first day. We'll do an overview. We'll talk briefly about mucogingival surgery, from the basics to the diagnosis, the general principles, and general techniques, of course, with case discussions, surgical video visualizations, and a hands-on workshop at the end of the day. And then the second day of the course will be more about crown lengthening. So hopefully in a 2-day, very intense and short program, people and participants will learn how to be, in simple cases, how to lengthen teeth predictably, how to shorten teeth predictably, to combine them into their overall treatment plans. And here we go back to the importance of pink aesthetics. And I always like to approach every topic asking myself or asking the participants 3 questions. What are pink aesthetics? What are they important? And how can we improve them for our patients? What can we do for them? And as a brief introduction, the concept of a aesthetic smile has changed a lot over time. We have the tendency now to go towards wider smiles, bigger smiles that show more teeth, that show more gingiva. And if we look at videos from TV, from movie theaters, etc., we ask ourselves what makes a beautiful smile. Again, we're shifting towards wider smiles, bigger smiles, where we show more teeth, and also maybe me showing more gingiva. But the gingiva that we show in the smile, we have to ask ourselves, what is ideal? What rules do we need to follow? Who's got an ideal smile? Because it's very easy to determine if teeth are good looking, if teeth are beautiful. We can change the shape of the teeth. We can change the color, everything of the smiles of our patients. But sometimes we forget to take care, we forget to look into the pink aesthetics of the smile. And again, we need to understand what they are, why are they important. We need to understand how we can improve them for our patients, and what can we do to improve our techniques and our protocols to improve the predictability of our treatments. Because there's different aesthetic problems that can alter the smile of our patients, but only touching and only affecting the pink aesthetics, which hopefully after this webinar, people will have more idea of how can we improve. What problems can we have? We can have altered passive eruption. We'll talk a little bit more about that later when we show too many gums. Trauma in the teeth or trauma in the gums can lead to altered tooth eruption and lead to problems. Any abnormal habits, gingival hyperplasia, so when the gum is enlarged, gingival recessions, when the gums recede and the teeth seem longer than they should, or then with orthodontic treatment or tooth malpositions, we can also have some slight problems in these pink aesthetics. And when a patient, for example, like Chris, comes to us because he wants to get his central incisor back, we're going to have a very, very challenging scenario in which if we only take care of the white aesthetics, we only take care of providing that tooth, we're not going to have an ideal outcome. And in this case, since when he smiles, he shows so much gums, taking care of the gums, that scenery where the tooth is going to sit to obtain a successful treatment outcome is going to be just as important as creating a crown that is exactly identical to the adjacent teeth. So we cannot plan these cases. We cannot, even whether it's one tooth and mostly when it's more teeth, without taking care of also planning what do we want to do with the pink aesthetics around teeth, if we want to lengthen, or around implants. So we always need to be considering the pink aesthetics part of the treatment plan since the beginning of our treatment, since the first time that we see a patient. Because again, also not only around teeth, but also for implants, when we're about to restore a tooth with an immediate implant, place an implant, place a connective tissue graft. Implantology is not the main aim of today's webinar. We'll be mostly talking about teeth. But if we want to obtain a biomimetic result, if we want to obtain a good result that simulates the adjacent teeth so that nobody can tell where there's an implant or not, just as important as taking care of the crown, just as important as placing that implant well, it's going to be taking good care of the soft tissue and taking good care of the pink aesthetics of our patient. So for example, this was one of my best friends from Madrid. He came to me, he said he wanted to improve his smile. He also had a high smile line, and whatever he had in his in this area, he would show in the picture. So if we ask ourselves, what is wrong with the smile? There's gingival health. We have teeth that have good shapes. They're beautiful looking teeth. They're aligned teeth. But there's just, if you see, there's an imbalance. There's a mismatch between the first quadrant and the second quadrant. And asymmetries, it's been demonstrated that it's what people notice most as a problem in a patient's smile. So if we do a digital smile design, and again, I'm not going to do veneers in this case. I'm not going to do any type of restorative treatment. I'm just doing this to plan the balance between the pink aesthetics in the right side and the left side. I see that in the first quadrant, he has a little bit of altered passive eruption in tooth number 12 in the lateral incisor, which is making it be short. Whereas in the second quadrant, he has gingival recessions in 22 and 23. And this is causing an asymmetry that is making this smile pretty anesthetic. So now with mucogingival surgery or periodontal plastic surgery, which is what we're going to be talking about today, combining a resective approach. So we're going to lengthen the tooth number 12, and we're going to bring down the soft tissue in the second quadrant with a coronally advanced flap plus a connective tissue graft, which will not have too much time to talk about it just today. I can perform in mucogingival surgery, and in the same surgery, take care of both sides to shorten one side, to lengthen the other one, and have a much more aesthetically pleasing, much more balanced, and much more harmonious smile between the right side and the left side. So again, what is mucogingival surgery? It's a surgical periodontal treatment aimed at correcting defects in either the morphology, position, and or quantity of soft tissues around either teeth or implants, although we're going to be talking mostly about teeth today. And what indications can we have? We can increase the keratinized gingiva, we can have root coverage, improvement of the phenotype, which is the soft and hard tissue around the teeth or the implant. We can also, when we're missing teeth, correct the size of the ridge and the shape by means of volume augmentation. We can also remove aberrant frenulums, exposure of impacted teeth, or crown lengthening, which we'll be talking mostly about today. And just so you can see some of the indications of soft tissue surgery that, again, we'll be able to talk about them more in detail in our upcoming course in Turkey. We can obtain increase of the keratinized gingiva to increase the keratinized tissue around teeth very, very predictably. We can also use mucogingival surgery, as we saw earlier, to cover recessions. When we have recessions like this, making the smile very anesthetic, we can, by means of mucogingival surgery, connective tissue grafts, and in this case, also combined with restorative work by veneers, obtain a much better, more aesthetic outcome at the end, combining white aesthetics and pink aesthetics treatment. We can also improve the peri-implant phenotype around implants, giving it a more soft tissue volume, which is not only good for aesthetics, but also for long-term peri-implant health. We can also increase the volume of a ridge when we don't have teeth, so that we can increase the volume of that size and play with our crowns, play with our soft tissue management to have a more harmonious transition between the soft and the hard tissues. Eliminate aberrant frenulums, sometimes for aesthetics, sometimes for functionality, sometimes for health, also following mucogingival surgical principles. Exposure of included teeth to make sure that they leave an aesthetic outcome in the end, and also healthy, make sure that the peri-implant periodontal phenotype around the tooth is ideal for long-term stability, or something which we'll be talking a little bit more about today in one of my most passionate projects, because this is truly one of the ways in which we can directly impact the smile of one of our patients with periodontal plastic surgery, is crown lengthening. Why do I like this topic so much? Because it's always patients like this, very nice patients like Danisa, for example, that come to their clinic, and whether it's localized in one area or whether it's generalized in their whole mouth, they're always self-conscious about their smile. They might not like their smile. They say that they show their gums too much, their teeth are short, and they're people that are very self-conscious about smiling. Why? Is it because of the teeth? Yes, she does indeed have short teeth, small teeth, but is her problem in her teeth, or is her problem in her gums? And can we do something about it? Again, we need to ask ourselves, why does she have short teeth? Does she just have short teeth, or does she actually have longer teeth? Can we lengthen them? And also, will this be stable for the patient? And is this going to be predictable over time? So for this, to understand this, first of all, we need to go back to the basics, and we need to understand anatomy and biology. Because whenever we do periodontal plastic surgery, whether it's to lengthen the teeth, to shorten the teeth, we're going to be dealing with a very small area of the mouth, the oral cavity, which is the periodontal attachment apparatus, in which we really need to understand the structures in that area, because that's where our blade is going to go, or our laser is going to go, whenever we perform any kind of aesthetic treatment. So we really need to understand the anatomy and the relationships between the gingiva, the periodontal ligament, the cementum, the alveolar bone, and the alveolar process, which are the elements that make up the periodontal attachment apparatus. And today, we're not going to go too deep into histology. We're not going to go too deep into biology, but it is important that we differentiate some structures: keratinized gingiva, which is composed by the free and the attached gingiva that acts as protection for the tooth. And then once we go past the mucogingival junction, we have the alveolar mucosa. Well, let's just say if we have lack of keratinized gingiva, over time, the prognosis of the tooth might be slightly worsened if the patient does not have a very good oral hygiene. So taking into account planning for crown lengthening, some structures that we really need to take into account are this mucogingival junction that we just talked about, the position of the alveolar bone crest, and also the cemento-enamel junction, which is the point in which the crown ends and the root starts, and it transfers from enamel into root cement. And again, the anatomy, biology follows some very strict rules that we need to follow. And mostly, and that's why I asked earlier, do we know that our treatment is going to be predictable over time? If we want our treatment to be stable, to be predictable, and the result that we provide the patient in the short term to be stable over time and not have problems like inflammation, like recession, we really need to follow the rules of biology. We need to follow this biological width, or now called supracrestal tissue attachment. We need to respect it, and whether we move the gingival margin one direction or the other one, we need to preserve this for long time stability. And this is composed of the junctional epithelium and supracrestal connective tissue attachment that are attached to the root of the tooth. And this has recently been termed supracrestal tissue attachment. And how much does this measure? There's been a lot of studies, but on average, this measurement can vary a little bit depending on the level of inflammation. The connective tissue attachment is very stable. Junctional epithelium can vary slightly, but if we have to make a rule of thumb, let's just say that the supracrestal tissue attachment is going to be around 2 millimeters in healthy patients, and then there will be the oral sulcal epithelium, so the sulcus, which will be around 1 millimeter. So whenever we're planning for our crown lengthening cases, what we will need to respect is the CEJ to the alveolar bone crest to have a distance of 3 millimeters. And what happens if we don't respect this? We can have problems like gingival inflammation, bone loss, gingival recession, or soft tissue rebound. And the treatment that we provided our patients will not be stable over time and will be useless. So moving on more in detail to the topic of aesthetic crown lengthening, when a patient comes to us with this situation, what do we need to think about? What do we need to start assessing? Again, it will be the same chief complaint as we saw earlier, similar patient profile that does not like her smile and is a little bit concerned, self-conscious. And we need to determine what is the condition that this patient has. We call it gummy smile, but the technical term is excessive gingival display. And it's been described as a non-pathologic condition in which the patient shows more than 3 millimeters of gingiva when smiling, which can cause aesthetic disharmony. And again, to understand and to treat a problem, first we need to really know the etiology. We need to know why is this happening, to know what can we do for the patient and how can we improve it. And the tricky part about excessive gingival display or gummy smile is that in most of the situations, it does have a multifactorial etiology, which can have more of a skeletal etiology if the patient has a vertically increased, very tall maxilla or dental-alveolar extrusion of the teeth within the maxilla. It can also be more muscular if it's associated with lip hypermobility, so lip that moves up when the smile more than it should, or patient has a very short lid, or what we're going to treat as periodontal plastic surgeons with our surgery is if we have altered passive eruption, which means that the teeth indeed are longer than shown, but the gums are covering it too much. For this, it's very important when we approach this case, and not only these cases in which we have a full mouth of altered passive eruption, but also those cases where you just want to do 1-2 veneers, 1 or 2 restorative treatments, and the teeth are too short and you need to lengthen them. You need to go through this whole diagnostic evaluation, of course, from medical history, but then going into the face, the lip, which is what's going to tell you how much those teeth are going to be shown. It's important to analyze the incisal edge, because if we see a short tooth that has, for example, 100% ratio, we need to understand really if this tooth is short because it has been worn out or because the gum is taking too much of this space. And for this, we need to know the ideal ratios of the teeth, whether they're too long, whether they're too short. Ideally, a central incisor, we want to be around 78 to 80% would be what's considered, according to classical papers, as an ideal ratio. And in this case, the first clinical sign is going to be having very short teeth that we will need to lengthen. But again, how do we know if there's more tooth beneath the gum? How do we know if we can just by taking out some of that gingival tissue, we can lengthen the tooth? Or maybe the tooth is just this way. And if we really want to lengthen it, we need to think about other options like restorative options, veneers, etc. So we start to plan and we start getting all the information from our case. And based on the different multifactorial etiology, if we determine that different etiologies are the main cause of this problem, there will be different treatments that we can perform. If we have more skeletal problems, we might need to do orthognathic surgery or orthodontic therapy. If we have more muscular problems with techniques like Botox or lip reposition, lip reduction, we can improve this. However, the problem is that they will be temporary and they'll probably rebound back. And the topic of today, periodontal plastic surgery, is what's going to help us when we have gummy smile due to altered passive eruption. And this always, we need to consider the combination treatment of altered passive eruption and gummy smile correction with restorative therapy. And we talk a lot about altered passive eruption, but we need to really understand this topic as a developmental problem in which when the teeth are erupting, supposedly the gum follows there's the active eruption where the gum follows the tooth, but then when the tooth finds contact, the passive eruption process starts where the gums go and the bone goes and finds the original position. However, if there's an alteration in this process, is when these relationships can be altered, leading to what usually we deal with aesthetic concerns, or if not, we might have to do crown lengthening also for functional concerns if we want to restore. And according to this classification, and again, based on the relationships between the CEJ, the bone crest, and the mucogingival junction, there will be different types of treatment that we need to perform in each situation. So properly diagnosing this is just very, very important to perform a good treatment and to obtain good treatment outcomes. And based on this, again, we will be able in the course to go in detail about how to treat each specific situation of excessive gingival display, how to do crown lengthening in each specific situation based on the CEJ, gingival margin, and alveolar bone crest, or if we want to perform crown lengthening due to caries, due to cavities, due to functional crown lengthening, restorative, etc. It will all be treated by means of two very basic principles. Number one will be gingivectomy, which is we need to really understand how much of the gingiva we need to take out, and by means of a blade, by means of a laser, we can take that out exactly to the reference that we need. And sometimes, and this is it's overseen many times in most of the crown lengthening cases, gingivectomy sometimes, many times, most of the times, is just not enough, and we need to raise a flap, we need to evaluate the bone, and we need to do osseosurgery, not only in height, but also in width, to thin that bone and create a nice architecture. So again, based on the different types of altered passive eruption that we might have, there is different treatment alternatives, different treatment options. We don't have time today, and it's not the main aim of the webinar to go more in detail about the different treatment alternatives for each specific situation. But again, in our course in Istanbul, we'll fully go over every single step so the participants can predictably do crown lengthening in every single clinical situation. But again, moving on to clinical cases, another very typical case, patient that comes to us, she doesn't like her smile, she shows her gums too much, and she was very self-conscious about it. So again, we have a clinical phenotype very compatible with altered passive eruption. We have very thick, bulky tissues, lots of keratinized gingiva, and short teeth. But again, we need a proper diagnosis. We need to know exactly where the gingival margin is in relationship to the CEJ, in relationship to the alveolar bone crest. So there's different ways we can do this. And again, we'll go into all the different diagnostic ways, possibilities. And even if you just want to do crown lengthening on one tooth for functional purposes for a crown, the concepts are the same. You just need to understand where your references are, and based on that, plan your gingivectomy and plan your osseosurgery. So once we have the information by the probing of where the end of the pocket is, we can try to identify the CEJ, but it's very hard. Bone sounding will allow us to sound to the bone and know the exact distance from the gingival margin to the bone. And in these radiographs, you see we place some gutta percha on the gingival margin to know exactly where the gingival margin was, to identify all of these structures. And based on this, we perform a diagnosis of altered passive eruption, and we go ahead and proceed to the treatment, which in this case, from this baseline situation, we'll go briefly over the surgery. We decided, since the patient had a very nice profile of the soft tissues, we decided to just maintain this architecture of the soft tissue and just raise a flap. and you see we had initially 8 millimeter tall teeth, which usually we can expect a central incisor to be around 10, even sometimes 11 millimeters, but this one, she had a little bit of a worn out central incisor. So after raising a flap, we see that indeed her teeth are significantly longer than she was showing, and the relationship from the bone to the CEJ is not so wrong as it can be in other situations where the bone is right at the level of the CEJ. However, it's not allowing for that establishment of that supracrestal tissue height to establish at a position where the gingival margin will be at the level of the CEJ. So what do we need to do? Check that her tooth is truly 10 millimeters to the CEJ. And from this position, we create, by means of osseous surgery, ostectomy, and osteoplasty, the sufficient space for that supracrestal tissue height, those 3 millimeters from the CEJ to the bone, to establish the new biological width that we're talking that's so relevant in a more apical position, so that once we suture the flap, the same flap, in this case, we didn't even perform gingivectomy, in a more apical position, after healing, these 10 millimeters that we have in the post-op situation will be respected not only at 1 month, but will also be stable over time and give the patient the length of teeth, expose her true potential, not only at 1 year, but hopefully will be stable throughout time, so that we can improve her smile from her baseline smile to a more smile that shows better ratio of white aesthetics to pink aesthetics. And again, initially, I told you that the questions that we need to ask ourselves is, what is the issue? What can we do to solve it? But not only this, how can we improve our protocols so that our treatments obtain better results and are more predictable? So now I showed you a case where we had planned everything the analogic old school way. We'll go into digital protocols. Why? Because there's evidence that about almost 50% of the aesthetic crown lengthening cases in the maxillary anterior region have a rebound between 3 to 6 months. That means that 1 out of every 2 cases has a failed result, because if it's a highly aesthetic treatment and we need to lengthen the teeth of our patients, and 6 months later, 1 out of every 2 patients is going to have a rebound, that means we're failing with our treatment. And probably not with the treatment part, but with the planning, the diagnosis and the planning part, which are very, very, very relevant for our crown lengthening procedures. And how far can we go with this digital protocol? We can go as far as we want, thanks to the tools that we have. We have, wait 1 second. Let me make sure, yes. Okay. Sorry for that. I just wanted to make sure we're in the right presentation. We have recently published this protocol in which, together with my colleague, Ignacio Pedrinati, we've implemented a digital protocol in every step of the crown lengthening procedure since the diagnosis all the way until the execution, which would aim so that when a patient comes, like for example, Sonia, with the same chief complaint as all the patients that we've seen before, self-conscious about her smile, showed too much gums, we can perform, of course, clinical evaluation, see a clinical situation similar to the situation that we had been seeing earlier, and we clearly have a gummy smile. So we ask ourselves, do we have altered passive eruption? It seems like it, but we do need to go through our whole diagnostic evaluation. And now we're just going to do things a little bit different, and we're going to use the tools that we have in our clinics that everybody has access to, a CBCT machine to obtain a DICOM file, and also to an intraoral scan to obtain an STL file. So that what can we do with these 2 files? Here we have all the information about the hard tissues and the soft tissues. So we don't need to be guessing with our probe. We don't need to be bone sounding. We can just superimpose these files so that in one single software, we have all the information from the hard tissue, all the information from the soft tissue, which will give us this information about the CEJ, the gingival margin, and the alveolar bone crest. So we can analyze the space for the biological width of this patient if indeed she does have part of her teeth hidden under her gums, indeed if we can lengthen them, if we need to perform gingivectomy, and if we also need to perform osseous surgery. So we have all of the answers to all of our questions in the diagnostic and treatment planning phase. We have them thanks to just taking these 2 very simple files and putting them together. Also, we can do this in every single tooth to have a site-specific diagnosis and site-specific treatment plan. Diagnose that indeed we have ultrapassive eruption type 1B, but now we can even go further. And most of the planning softwares now allow us to do what we call virtual tooth segmentation, and we can extract the information from each one of these teeth individually. And what do we do with this? With information from the teeth, we turn it into a file in which with the design software, and this is just going a little bit over the top for our patients, we can create a wax up so that we can show our patients how the result is going to look in their own mouths. What do we do with this file? We print it with a 3D printed, and we have a 3D printed wax up in which we can show the patient in her own mouth how her own teeth are going to look after the surgery, after the treatment. And indeed, we saw that we have 3 more millimeters. We printed the veneers, and you can see how we show the patient how we can lengthen 3 millimeters predictably in her own smile. And why is this very important? Because we talked about how gummy smile has a multifactorial etiology, and in most cases, it's different factors. And now we're only treating the ultrapassive eruption part. So are we going to fully resolve her gummy smile? No, we're not. We're going to improve it. We're going to improve the white to pink aesthetic ratio of her smile. However, it's not going to fully be resolved because here probably this patient would need some sort of skeletal treatment, some sort of muscular treatment. However, she has seen how far can we go. She's very happy with the results and very excited about what we can obtain with just one single surgical intervention. So once she accepts this treatment outcome, we go ahead and we turn the same plan, which is based on the shape of her own teeth, we turn it into a guide that we can take during the surgery and can make the surgery much easier, much more predictable for different levels of skilled, and does not require you to be a very skilled surgeon to perform this surgery, which is a basic crown lengthening surgery in which first we perform the gingivectomy. In this case, we did it with a laser. We expose a flap. And here you see, for example, in picture G, how the bone is much, much, much closer to the CEJ in this situation. So we need to perform osseous surgery, move the margin of the bone apically to create that space for biological width to have this result be stable, not only at 1 week. We're not really going to see the whole surgery, but all of these cases, we have the surgeries documented to learn about every single step. And this is a follow-up at 1 week, which pretty much looks like surgery wasn't even done, but we don't care about the stability at 1 week. We don't care about the stability at 2 weeks. What we want to make sure is that not even at 1 month, this treatment is stable at 12 months. This treatment is stable over time. Why? Because we've planned, we've diagnosed, and we've made sure that everything goes according to the biological rules, and we've respected the biological width of our patient. And we can check the stability, we can check the length of the teeth, how indeed they're 11 millimeters in this patient, both central incisors, and everything is according to what we had planned initially. So have we fully resolved the gummy smile of this patient? No, we have not, because again, there's different etiologies involved in the gummy smile of this patient. However, we have predictably improved significantly the white to pink aesthetic ratio. So her smile is much better because we've taken also care of the pink aesthetics. And these digital protocols are useful for different ultrapassive eruption types. They're very useful, and we'll go more into detail in the course about how to combine these crown lengthening treatments with restorative treatment, because many times, for example, we just need to perform a gingivectomy. In some cases, we can use this to just perform a gingivectomy, and in a very easy surgery, if it's indicated, predictably lengthen the teeth of our patients. We can also use them combined with restorative work, whether it's veneers, whether it's crowns. Sometimes the tooth itself is worn out and it's not enough, it's not beautiful enough, or it doesn't have enough length to just leave the tooth by itself. So we need to combine it with restorative work. And here it's very important to respect that biology, respect that supracrestal tissue height, respect the healing times. So it's very important to have an ideal restorative protocol when we're going to combine it with crown lengthening, so that we don't have in the future what is very common: patients that have anterior crowns or veneers and they have inflammation at all times, lots of bleeding, or even recession if they have a thin phenotype. And again, many times we combine it with prosthetic treatment. For example, look at this case right here, in which is a software about digital smile design called SmileCloud. This patient had a combination of altered passive eruption, but also altered active eruption, very, very worn out teeth, and wanted aesthetic, a smile makeover. See how we're doing the full diagnosis. We're taking care of the lip, we're diagnosing the teeth, the incisal edge, everything. We're taking care of everything. And the good thing now is that we can plan, thanks to softwares like SmileCloud that we will learn to use based on digital AI-based libraries. We can perform wax-ups that take into account correction not only of the white aesthetics part and perform the DSD, but they also take into account the soft tissue profiles, and we can take into account different planning, not only from a white aesthetics perspective, but also from a pink aesthetics perspective. And once we design and the final design of the crowns that we want, we will plan accordingly the crown lengthening procedure that we will need. So again, see here with SmileCloud, we can create based on these digital libraries, digital smile designs that we like. We can correct the papillas, we can correct the gingival margins, we can correct the incisal edges. We're not limited only to the shape of the teeth, but we're also considering, see, how much do we need to lengthen each tooth? How much are we going to lengthen to have a harmonious smile so that he shows the ideal amount of gingiva so that everything is balanced between one side and the other one? And now we just need to follow a protocol to obtain this result, not only in the computer, because of course, when you use a planning software, the computer takes and accepts everything. Anything can be done in a computer. Now you need to turn that into reality, but not even short-term reality, but long-term stability in a long-term situation for the patient. So that once we have the wax up and the situation that we want to perform, we see we're going to need to perform a crown lengthening surgery. Again, based on a proper diagnosis, we will ask ourselves, can I only do gingivectomy, or do I also need to do a crown lengthening surgery? And again, here is a digital plan in which we will see how from the gingival margin of the ideal desired final gingival margin, we don't have enough distance to the bone. So we're going to need to raise a flap, have some sort of intrasurgical reference of where we want to end with the margin of our veneers, of our crowns, have a reference ideal intrasurgical, and as you see, the margin, the CJ of our crowns is going to be right at the level of the bone. So we're going to need to make a pretty significant osseous surgery, in this case, osseous resection, to create space for that crown lengthening. And again, I can't emphasize this enough. When we're dealing with cases like the previous ones, when we just have altered passive eruption and all we're going to do is expose the real tooth of the patient, the biggest consequence if we don't perform enough or well enough osseous surgery planning is that there's soft tissue rebound, and over time the teeth will become shorter. But if we do this, and a very common mistake is these very fast protocols where crown lengthening is performed and 1 month later crowns are placed or veneers are placed, this will create a very improper relationship between the crown margin, the bone crest, the supracrestal tissue height, that will lead to periodontal problems in the aesthetic area for the patient for a lifetime. So these rules really need to be understood, really need to be followed, spaces need to be respected, and also osteoplasty needs to be made to thin out that bone and create ideal relationships. And once we have this, we've created enough space, we suture the flap, we wait for healing, we wait for proper time. 6 months later, we're going to perform significant crown lengthening to obtain the final situation, final impressions, provisional restorations, and then the final restorations that if we check, they look exactly like we had planned. So if you check the second and the fourth photograph, it's pretty much a representation from the ideal planned situation to the final result. Why? Because we've planned it, we've diagnosed it well, we've planned it well, we've used the digital tools that we have in our hands to make this treatment more predictable, and we have also followed all the biological principles along the way. So it's very important to diagnose well, it's very important to plan well, and it's very important also to execute. And if there's mistakes in any of these steps, is when we can have significant issues. So again, crown lengthening will be one of the main topics of the course that we will have upcoming in Istanbul will be more centered around pink aesthetics, different scenarios. Today was just the aim was to be the show the tip of the iceberg. We'll talk about how to lengthen teeth, how to shorten teeth, both around teeth, implants, and cases with crown restorations. And this is just a video of the last edition of this course that we had in Dubai a couple of years ago. We were supposed to also have it last year, but it was exactly the week that Dubai got completely flooded by the rain. So it was impossible, but it was a very successful course. We'll have the same structure. And if any of you guys have any more questions, you can ask Dr. Sarah or myself about more information. And again, we'll have day one based on mucogingival surgery. We'll learn how to harvest different types of grafts, techniques. We'll have a hands-on workshop about how to use what we call the periodontist's gold, a connective tissue graft, to solve different scenarios, to solve different situations for patients, to use them to shorten these teeth when they have gingival recessions, which can be very, very useful in many of the restorative cases. Like, for example, this one, where just restorative work is not enough to solve the smile of a patient. Because if we just perform restorative work, we can either leave a completely asymmetrical smile, or we can just leave the recessions that are yellow, and they'll be very contrasting with the restorations. So in many, many cases, even for restorative dentists, even if you guys are not going to perform the treatment, it's good to know the solutions that we have, the alternatives that we have, to plan the cases, not only from a white aesthetics perspective, but also from a pink aesthetics perspective. And then day two will be more about what we have seen today: crown lengthening, when to perform gingivectomy, when to perform osteosurgery, how much osteosurgery to perform around crowns, around veneers, around fractured teeth, in different clinical scenarios that will also happen in your day-to-day practice, but also in highly aesthetic crown lengthening cases like this one, or for example, like this one that we just saw. We'll also have a hands-on workshop, both days for mucogingival surgery, for crown lengthening, in which hopefully once you start seeing cases like this, you'll start seeing different problems, different issues. You'll be able to plan them. Hopefully one day you'll be able to solve them, and also combine your restorative treatment with mucogingival treatment or restorative treatment, as well as crown lengthening, to see your cases from a more comprehensive approach, not only taking care of the white aesthetics, but also taking care of the pink aesthetics for your patients. So thank you very much, Dr. Sarah. You said 40 minutes. That was 41 minutes. So I think I was pretty close to the time. Again, I didn't want to take too much time off anyone's Sunday, wherever in the world they are. Here in the US is lunchtime. In Europe is probably, or Middle East is probably dinner time. So thank you very much. And I hope everybody enjoyed that webinar. And I'm at the disposal of anyone if there's questions, and we can have a nice discussion.
No, honestly, thank you so much, Dr. Calatrava. And as a person here said in the comments, impeccable as always. And I definitely agree. 41
Thank
minutes
you very much.
At all. We do have a couple of questions, so I won't take too much of your time. But one of the first questions we have here is, what software do you use to combine the DICOM CBCT and the STL? So,
okay, that is a very good question. Who is this person, so I can address them directly?
Their only initials, MO.
Oh,
so Dr.
okay,
M.
so Dr. MO. That's a very good question. Okay, there is a lot of available softwares now. Let's just say that any digital planning software, any implant planning software, at this point will allow you to use this function of superimposing DICOM files and STL files. I don't know if you have any software in particular that you're asking about, but for example, you've seen, well, through the presentation, there's been different softwares. This right here, I could recommend let's just say each implant commercial brand usually works with a software. They're all very good, but there's this one right here is Blue Sky Bio, which is a free software available online. You can go right now on the internet, is BSB, Blue Sky Bio. And you should be able to download it for free, whether you use Windows, Mac, and it's very useful. There's a lot of tools, and this and many other more things can be done. These are all screenshots from Blue Sky Bio, as you see. the outline, the pink outline represents the soft tissues, and then it's the CBCT information. And these are all screenshots from just Blue Sky Bio, in which as soon as you import the CBCT file, I think with the new AI wizard that they have, it will ask you, do you also have an STL file to add? And even the AI planning software now adds it by itself. Just make sure through the slices that it's accurate, and you should be able to use this information. But this can be done not only for this, but for many other reasons, for implantology, for treatment planning. If you have a wax up and you want to plan the implant. So this tool of superimposition of an STL file with DICOM file for current day treatment planning of any field, I think it's a very, very, very useful tool. And like I said, I think it's available in pretty much all of the softwares. But great question.
Perfect. Perfectly answered as well. Thank you so much. We have a couple more questions left. One of them is, why do we need to wait for 6 months after crown lengthening for the prosthesis phase?
That's a very good question also. So, and this can lead I know this can lead to discussion for many restorative dentists, and it's something that always comes up. So, let's just say that when you perform crown lengthening with a gingivectomy and an osseous surgery, and then you're going to restore with the restorative work, you're going to alter in that interface between the tooth and the gums, you're going to insert another margin, which is going to be either the crown margin or the veneer margin, most likely, or a restoration, whatever. And you need to wait for complete healing of the periodontal attachment after crown lengthening, which it's been demonstrated to be from 3 to 6 months. So why 6 months? Could you do a little bit shorter? Yes, you could do a little bit shorter if the crown lengthening was not very extensive. But if you want to be very precise, and see here, we're not dealing with functional crown lengthening and posterior molar. We're dealing with highly aesthetic treatment in the anterior area, in which you really need to make sure that all the relationships are there and are going to be stable. And from 3 to 6 months, as we saw, there's literature that there's going to be significant rebound in a lot of cases. So hopefully, we're going to do a very good treatment plan so that we don't have that rebound. We don't have that change in the gingival margin, and whatever we leave it, it will stay there. However, sometimes the patient might need a little bit more supracrestal tissue height. The phenotype also plays into account. Sometimes patients with very thick phenotype have a higher tendency towards receiving of the gum to its original position. And those are the cases where if you put the crowns too early, then you'll see patients that have beautiful looking crowns, but they're always inflamed. And you have the gingival margin around those crowns that is always inflamed. Or not only that, that's what will happen if they have thick tissues, but if they have very thin phenotype, what can happen is the opposite. If we're invading that supracrestal tissue height, or the supracrestal tissue height tries to reestablish between those 3 to 6 months in that area where the veneer margin is, where the crown margin is, it might not like it, so it will go back and recede by itself, causing recessions on the long term. So the recommendation based on literature is that if you want to be very cautious with a high aesthetic treatment, patients that overgo treatment, pay a certain amount of money for this treatment, and you want to make it stable and aesthetic over time, to wait for 6 months. This doesn't mean that in the process, you can't have provisional restorations. You can have provisional restorations in that time, give the patient that aesthetic look. Mostly, if it's one of those cases, like for example, this one that I showed, that the result after the crown lengthening is not very aesthetic for the patient. So here you can for sure go into a provisional stage, which is not going to be the final situation, but it's going to be a much better situation than what we have given the patient. However, if just after crown lengthening, like just in this moment, a couple of weeks later, we go ahead and we perform the restorations, it's very, very likely that we have problems in the future, health-wise or aesthetics-wise. But that's a very nice topic of discussion. And I just think that the tendency is to wait too little for the restorations and not allow enough time for healing.
Understood.
So thank you very much to Dr. Luin Mo Ong for that question.
Thank you. Thank you so much, Doctor. We have an inquiry regarding the course itself. So will the course be on models or on sheephead?
Okay, that is a very good question also. So we last time we did the course, we did it on sheephead, but
Sure.
personally, we're shifting more and more, and I feel there's a big tendency towards working with models because we've already made some customized models. It's customized models from a great company that we have a model for crown lengthening, we have a model for soft tissue for mucogingival surgery that has let's just say the feeling for the participants is much more realistic than working on a sheep head or an animal heads, and then they have problems. The anatomy is different in each one. So this is a model that we've created specifically for this course. And then also we have some other things, some other surprises that we will not disclose, different specific models that we'll work on for graft harvesting practices. But yeah, we'll have specialized models just for this course for the participants.
Great, great. Our last question from Dr. Johanna. Why measure the distance from the lip towards the tip of the nose? Great.
That's another great question. So we'll go back, and that's why I have the presentation for support here. Again, and we didn't have, time was limited today, but that was a little bit also the aim to answer some questions and raise some other questions. Again, we mentioned how important the multifactorial etiology of gummy smile. And again, we have 5 different etiologies, and 2 of them are concerning the lip. One is lip hypermobility, and one is short lip. So how do we determine if we have a hypermobile lip or a short lip? If we have a hypermobile lip, we need to check where the lip stays in resting position, and then in full smile, how much does the lip go up, which in average in a woman is from 6 to 8 millimeters. If it goes more than that, it means that it's a hypermobile lip. And we also have to make sure that we don't have a short lip. A short lip, we measure it from the subnasale here to the bottom of the lip. And on average, the lip, again, of a woman this age, there's slight differences in measurements between male and females, just very, very slight, is around 20 to 22 millimeters. So if we have a short lip, and even if we have a short lip combined with a hypermobile lip, whatever we have is just gonna show in the patient's smile. And this is also very important. I mean, the aesthetic, the line of smile, how much it goes up and down, is also very important when we're treatment planning any restorative case, any implant case, or any case in general. So we need to stop looking at smiles as in teeth. We need to think about the teeth that we treat and we care a lot about and give us that beautiful aesthetic look within not only the environment of the pink aesthetics, but also within the lips and within the smile itself. So we need to start looking at smiles more as a whole. And here, dynamics are also very important. That's why measuring the lip length and lip mobility is very important in these cases. But thank you for another great question.
Perfect. Thank you. Thank you for all of your answers. And yeah, I believe that's it. Thank you so much for your time, Dr. Calatrava. And as you've mentioned before, our course with Dr. Calatrava is going to be on November 23rd and 24th in Istanbul, Turkey. So we would love to have you over. We're going to have hands-on as well, as the doctor mentioned. And yeah, Dr. Calatrava's course is actually 1 module out of 5 modules that we're going to have for a full comprehensive aesthetic and restorative dentistry fellowship program. So if you have any questions, please feel free to reach out to us through email or WhatsApp or on Instagram. And yeah, thank you so much for your time. It is a Sunday, as Dr. Calatrava mentioned. Thank you for your time, everyone, and we hope to see you soon. Thank you, Dr. Calatrava, for your time.
Thank you for having me, and thanks to everyone.